All right, can you hear me?
Yes.
All right, perfect. So I do have some slides because what would a reimbursement conversation be without a couple of codes and some payment values associated? So I'm going to attempt to share my screen right now and pull up some slides. Is that good?
It's good.
We're driving? All right, perfect. So as we were discussing, telehealth is really kind of changing the landscape of how your orthopedic practices are moving forward. And I think if we think about and we take a step back and understand, what kind of occurred prior to the coronavirus, digital health and these types of services were already in existence, but the big barrier to kind of adoption and that market really growing was utilization by your patients, right? So you could prescribe these types of digital therapies, but getting your patients to actually use them and buy into the technology was difficult. Well, the coronavirus has presented this amazing opportunity where they're basically forced to not only engage with you via telehealth, but also these digital health platforms. So it's really presented a great opportunity for this sector in digital health, but then also for you guys to think about how you may end up changing some of the way you practiced prior to coronavirus. So one of the big things to know about kind of from a legislative standpoint about digital health and telemedicine and remote patient monitoring is this idea of the waiver 1135 that was passed in March. So we're going to go through that a little bit. We're going to go through some of the codes and then the modifiers that are very important for you guys to attach to your claims. So to take a step back, for Medicare to cover telehealth, patients had to live in a rural area. They had to be an established patient, and you had to have had one face-to-face E&M visit with the provider in the last, I believe it was 3 years. And so, with this 1135 waiver, basically that landscape has totally changed. You can be a new patient. There are no restrictions from a area that you live in, so anybody can receive telehealth. The other thing is what constitutes kind of that device that you're using. The HIPAA compliance has been taken away from a standpoint that FaceTime, Zoom, all of these platforms are being allowed right now. There are specific platforms that societies have really gotten behind as to kind of, which ones are providing the most benefit for their patients. So from an overall standpoint, Teladoc is certainly the one that's kind of the buzzword right now, but I would really encourage you guys as physicians to think about right now, what platform is really providing me the most benefit for my patients? And that's information that you can take back to your society and together really work together to come up with a platform that really works for your specific specialty. The other thing is, physicians can now provide telehealth services from their own home, obviously, right? We don't want patients to be congregating in the waiting rooms. And there are 2 actual place of service codes that are important for you guys to know. So the place of service 2 is the one that you would use on your claims to indicate that you had a telehealth service that occurred at your home. And then you're also actually allowed to use place of service 11. So if you would have, performed that visit in your office, you can actually, indicate that would have occurred at your office as well. And even though you may be at home performing that, virtual visit, place of service 11 can be utilized as well. So I think one of the big things in that 1135 waiver that is very good for you guys to know is prior to this waiver, the E&M visits really could only be billed out and occur within your office. Obviously now with telehealth, the Medicare guidelines have included billing of the 992 series, which is really that established E&M visit that you would have used within your office. And I think the big thing here is that next year with the AMA and CPT, they were going to release new guidelines for E&M visits and kind of how you go from 1 to 2 to 3 to 4 to 5. Well, one big thing that was going to change in 2021 is this idea of time. And so, before it was kind of a long list of medical decision making, right? And kind of this puzzle game of like what constituted a 1 to a 2 to a 3 to a 4 to a 5. Well, 2021 said, you know what, we're going to look at the total amount of time that you spent with that patient, and that's going to be a big factor in determining which visit gets a 1, 2, 3, 4, 5. So think about that as you are kind of engaging with your patients over a week's period of time. You may have chunks of time that you may have had with a patient during a day. Well, that time should be totaled out, and you could potentially be using those 992 series codes as well. So one other thing for you guys to know is the specific modifier to use when you're using telehealth services, and that modifier is 95. Now, Medicare has also released a bulletin that speaks to modifier GQ, so you want to make sure that you're consulting with your local MAC and your private pay coverage, policies. There are some that have already been released for Aetna, Anthem, I believe, but you definitely want to kind of consult those policies as to which modifier would be most appropriate. I'm hearing that 95 is the modifier to go with. So again, those 992 series codes are very important. Obviously, also there are the telehealth services codes, remote patient monitoring codes. I think the big thing to remember with remote patient monitoring is there should be some type of vital or some type of physiological data that's being, interpreted from the device, potentially, that, would constitute the ability to bill out for a remote patient monitoring code. With RPM, the other great thing that was passed is the incident to billing concept, meaning that physicians are no longer the only ones that are able to bill out for these remote patient monitoring codes. And this really, allows you to kind of delegate some of those check-ins and checkups to your ancillary staff. So, I think one thing, if we take another step back, to think about, what does this mean for our clients, and what does this mean for kind of like for our landscape and the way that we do business. And, I think as the other panelists mentioned, telehealth is definitely here to stay. It will change the way that we practice over the back half of the year. And I encourage you guys to really think about kind of how you're incorporating it into your practice so that you can be a great advocate and be vocal with your society about how you want telehealth to be administered for your specialty. And this will actually relate back to payment, right? So other societies are already jumping on this telehealth bandwagon as well, and they're trying to advocate for better payment. And the more that you guys figure out kind of how this is going to be utilized most effectively, the bigger your voice can be back to your societies as well. So thank you so much.